Good evening. Good evening. Woo, all right. Welcome, everybody. We're so excited for you to be here tonight. We're really pleased to be hosting this very important discussion. My name is Kate Fuld. I'm Director of Hollywood Health and Society. Hollywood Health and Society is a program of the USC Annenberg School for Communication and Journalism's Norman Lear Center. And anybody who can repeat it afterwards gets a prize. But we just call ourselves HH&S. And HH&S is a free resource to the entertainment industry. So since 2001, so almost 20 years, we have supported TV and screenwriters and other content creators with accurate information and access to experts in the areas of health and well-being, medicine, science, safety, and security, so pretty much anything. We can provide you with on-demand support from everything from aging and older adults to HIV/AIDS, to lung cancer, addiction, mental health, incarceration and re-entry into society, nuclear weapons, peace and security, and pretty much everything in between. So feel free as writers, as content creators, to contact us if you have questions for a storyline you're working on or a character development you're working on. We're available to connect you with the right people. It's all free. We don't ask for a credit. We don't even ask for our son-in-law to get a walk-on. So, we respect all of that. Anyway, so we're here to support you in creating accurate and compelling storylines about all of those topics and more. We also host events like these to bring experts and storytellers together, and we honor impactful stories through our annual Sentinel Awards, which this year is planned for November 6th, so mark your calendars. And we hope to see you all there. So tonight, it's a grim topic, but it's a very important topic, and something that I'm thankful to know is getting some attention of late, and we're going to hope to help draw a little more attention to it as well, and also to applaud some of you storytellers who have told this story. The U.S. has the worst rate of the worst rate of maternal deaths in the developed world. We have the worst rate. It's dangerous to have a baby in the United States. Here are a few bullets from the recent NPR ProPublica project called The Lost Mothers, which you may have read about or heard about. I pulled these bullets from one of the articles. Hospitals, including those with intensive care units for newborns, so they're ready to go, right? But they can be woefully unprepared for a maternal emergency. So they're great with the babies, but mom's over there having trouble and everybody's forgotten about her. Federal and state funding show only 6% of block grants that are designated for maternal and child health actually go to the health of the mothers, only 6%. In the US, some doctors entering the growing specialty of maternal fetal medicine were able to complete their entire training without ever spending any time in a labor delivery room. These are just the facts. I'm just reading them to you. The CDC reports in the US, the risk of pregnancy-related deaths for Black women is 3 to 4 times higher than those of white women. And our record ain't so good for white women either, as you know. So what is going on? We're going to find out. We have an amazing lineup of panelists whom you're going to meet in a minute, but I want to give a shout out to a few people in the audience that you might be interested to know. First of all, Renee Montagne. Wave, Renee. I don't know where you are, but wave. Renee Montagne is NPR's special correspondent who was the co-host of Morning Edition for 12 years. She wrote and contributed to the Lost Mothers series I mentioned, which was stories of moms and this issue through a partnership with ProPublica and NPR. So thank you, Renee, for being here. Priska Neely, wave. Priska is senior early childhood reporter at KPCC Radio, and her producer, Stephanie Ritauper, is here somewhere. I got it, kind of. Priska did an event in January that some of you may have heard of called Racism and Reproduction, What Black Women Need to Know. And due to the overwhelming interest in this issue, she's now going to do another event on May 25th titled Wellness for Black Moms to Be, Resilience in the Face of Racism. Now, I think they're sold out, but she is here tonight, so you know. Yeah, I'm just saying, you might, you got friends in high places now. Anyway, and thank you, Priska and Renee, for doing these stories. And from Fox's medical drama, The Resident, we have a bunch of writers, I think, a few writers here from the show, somewhere in the audience. And we also have Kamal Bolden, who plays the character of Charles Johnson in the show. We have Vanessa Antoine, who plays Charles's wife, Kira, on the show. And Malcolm Jamal Warner, right here in front, who plays Dr. A.J. Austin on The Resident. So thank you. So a star-studded audience and panel. And just lastly, I just want to give a great shout out and thanks to the Hollywood Health and Society staff for handling this event, putting it together, handling all the details from your parking validations to the wine out there, to the food, and to who's sitting where. So thank you to Hollywood Health and Society staff. These guys, we couldn't do this without you. So applause for them. So among the materials on your seat when you sat down, there's a bio sheet on our panelists. So we're not going to spend a lot of time telling you who they are because you can read about who they are. So we want to get right to the discussion. So if you need to refer to your bio sheet, you've got it there. We also have in those materials an evaluation survey, which I hope you'll fill out before you leave tonight and just give us your impressions of this discussion and maybe something that you might be interested in hearing about in the future. So that's all the housekeeping, I guess. So that sounds like me. Okay, yeah, all righty then. Yes, and we are streaming live on Facebook, so everybody can say hi, everybody in Facebook land. Woohoo! And we have proof that we are because we just heard it on Karen's phone. So, anyway, so now let me introduce our moderator for this evening. This woman is a mother of 3 little ones, I think probably age 4 and under, if I'm not mistaken. 6 and under, all right, well, okay then. It's so much easier now, right? 3 little ones, 6 and under. She's also a medical doctor. She's executive producer of ABC's acclaimed Grey's Anatomy. Which, by the way, did their own storyline on maternal mortality last year, which she may talk about a little later. And she's also co-chair of Hollywood Health and Society's advisory board, and I like to call her a good friend. Please welcome Zoanne Clack.
Hello. I am incredibly proud and honored to have been asked to moderate this very important panel, and incredibly happy that I did not know about this when I gave birth to my twins. because I would have been incredibly scared. But just to set the stage for tonight's discussion, we're going to watch a short video from the Washington Post that highlights the topic and the journey of one of our panelists. So we'll just turn that on now. Now.
I have to deal every day with the fact that there's nothing that I can do to bring Kira back.
It's amazing. I love you.
Many are shocked to learn that the U.S. not only has the worst maternal mortality rate in the entire developed world, but that these rates are on the rise.
It was very possible that I wouldn't have made it. And the casualness by which the medical establishment treats something like that, it's like a second trauma.
The United States is one of very few countries in total and the only developed nation with a rising maternal mortality rate.
Where is that, Rayburn? That's right next door, right?
That's where we came
from. Okay. Yeah, I got pretty frustrated in my cologne. I was like, helping members of Congress to see the women that are dying, just the way that they would see their mothers and their daughters and their wives. As I'm sitting there, I look down and I see the catheter coming from her bedside begin to turn pink with blood. This is in the late afternoon, around between 4 and 5 o'clock. I'm concerned, but Kira's healthy, the baby's healthy. 7 o'clock comes, 8 o'clock comes, no CT scan. And at this point, we're begging, we're pleading, look, do something, please. Like, you can see that things are getting worse. It wasn't until after midnight that they finally took Kira back for surgery. Finally, they came open. The same 2 residents, along with the doctor who I'd never seen before, came through those doors, and they told us that she was gone. And there was nothing that they could do to save her.
No hay nada como el café de Puerto Rico. We had a date, everybody was planning to come for that date, but then I got preeclampsia. You know, and after about 20 hours, they finally decided that we had to do a cesarean. When I was back in my room, I started having problems with fevers. And they had said, oh, you have a urinary tract infection. And then within 3 hours of being home, I started spiking a terrible, terrible fever. I just had a massive infection of the wound, you know, of the incision, a massive, you know, I had an infection of the uterus. At one point I stood up and the entire incision ripped open and like blood started pouring out. It was like a horror movie.
What?
Charles really gives everyone the opportunity to see beyond the numbers. But Charles gives us the opportunity to understand the real impact that happens to fathers, to husbands, to families when we lose the life of a mother.
Hi. The only pictures that I have of Kira, so this is actually of Kira and Langston, is when, you know, he's in that blanket. Yeah. My older son, Charles, who's 4 years old now, he said to me, Daddy, I'm ready for Mommy to come out of the sky. And as much as I tried to explain to him that Mommy's not coming home, and I try and rationalize with his little mind why mommy can't come to his soccer games or why she's not there for the first day of school like his other friends' mothers. His little heart still has a void that I'll never be able to fill. Yes. Yeah. Roberto. Is everybody here for the movie? Yes. And it haunts me, the fact that if she had been Caucasian, that she might have been taken back to the OR an hour later, 2 hours later, that they might have made a little bit more effort to save her life, and that she would be here with her sons today. That's a difficult thing to process, and that's extremely painful.
Please welcome to the stage Charles Johnson. So, as was mentioned in the video, the Fox, or was it mentioned? The Fox medical drama, The Resident, actually did an episode based on Charles's story, and we're going to look at a trailer of that episode.
I know in this situation an apology is not enough. But from the heart of this hospital, I'm here to offer one. Your wife suffered what we refer to as a never event. Something that should never happen.
I got an email out of the blue from an executive at The Resident, and then she goes on to tell me, we'd like to do an episode of the show inspired by Kira's story and then dedicate the episode to Kira. And I was like, what? Kira went in for what was expected to be a routine scheduled C-section at Cedars-Sinai Hospital on April 12th of 2016, and we expected it to be the happiest day of our lives.
I'm scared. You're gonna be okay. Everything is gonna be okay. All right, I'll take it from here.
The doctor tells me she'll be back in 15 minutes. 15 minutes. And that was the last time I saw my wife alive.
This happens far too often to women of every color.
But it's 4 times more likely to happen to Black women. That's a fact.
The way that she touches people's lives and the way that her story resonates with people never ceases to amaze me. And I'm so honored to see these talented, gifted actors pouring their hearts into these roles. What we've accomplished together here with The Resident, just couldn't have a better time for us to rally and come together and raise awareness about this issue.
The United States is the most dangerous country in the developed world to give birth in. There's no excuse for that.
Women all over this country deserve better. There's no statistic that can quantify what it's like to tell an 18-month-old that his mother's never coming home. There's nothing I can do to bring Kira back, but the highest honor that I can pay Kira is to make sure I do everything I can to send other mothers home with their precious babies.
Please welcome to the stage the co-creator and executive producer of The Resident, Amy Holden Jones. And also joining us tonight are Doctors Monica McLemore and Karen Scott from the UCSF Family Health Care Nursing. Is that right? So we're going to start with Charles, man of the hour. Your story is just devastating. Are there other elements that you'd like us to know besides what we just saw?
I think that for me, the pieces that you all selected to share were just so amazing. But for me to sit here and have peace in my heart that the people that I trusted with something so precious to us poured themselves into it in such a magnificent way to get this type of result and took it to places that were difficult, but challenged not only themselves, but challenged the network, challenged everybody involved and everybody who set eyes on this project to look directly at this crisis for what it is. And so the biggest thing that I want to express before I express anything else is just gratitude. Gratitude to Amy, gratitude to Kamal, gratitude to Vanessa, gratitude, to Malcolm, gratitude to Chris and Tiana, and this wonderful extended family that I've developed through this process. So we're just grateful, eternally grateful. Grateful to all of you all who are here tonight in support of us. So that's the most important thing I want to express.
Well, it's definitely great that you're getting this message out and you're getting it to more people and it's being more accessible, because these are things we need to know so that we can then advocate and solve the problem. Amy, did you have any pushback from the network when he was talking about that?
Oh, we did actually have some pushback, but it wasn't as bad as you'd think. It was initially, first I actually want to acknowledge Chris Basunian and Tiana Langham, my co-writers of the episode who are here. I'd love you guys to stand up. They brought the story.
Are they hiding in the back? Are they hiding in the back?
They brought the story to my attention and showed me the footage of Charles testifying, and it wouldn't have happened without them. The network initially took the position, amazingly enough, that they didn't want anybody to be at fault, which is an issue we've always had with the show, because of course the show's kind of about people sometimes being at fault. They wanted it to be like systemic error. And then we wrote the script, and it was still very good. And happily, the first director on the show who didn't get to do it was Robert Greenlee, who is Black, and we have a staff member also, Marquis Jackson, who's Black, who didn't work on the episode, but he read it, and he and the initial director, who didn't get to do it because he got snowed in one of the crazy weather events that happened this year, both said, you're not acknowledging the racism in it. You're telling the story of maternal mortality, but you're not telling the story of the racism. And then that was hard for the network to do that. And I understand why. It was a little bit because they wanted, the maternal mortality story is an everyman story. They wanted that to be the case. And then the director, Rob Korn, who came in, said the same thing. He said, we can't ignore this. This isn't, and we went through many drafts and inched forward until we got to the final script. And to the internal credit of the studio and the network, once we got there, they looked at it and said, yes, we are telling this story. But it was not easy to get to that point. It definitely was not. And little known fact, at a certain point, everybody was so afraid of saying that there would be racism on the part of the doctors. There were murmurs, oh, should the couple be white? And I said, no. That is not going to happen. And they backed off of that. And I think it's like inch by inch you drag everybody over the finish line. And we're all really proud of it now. And the network and the studio are also really proud of it now. And very glad that we all arrived where we arrived. So was it easy? No, it wasn't easy to get there, but it wasn't impossible. And ultimately, they came behind the episode 1,000% when they saw it, 1,000%.
Well, speaking of racism, and I would also probably add in implicit bias, Monica, what are the top causes of pregnancy-related deaths in the U.S., and how does that differ for women of color?
Well, first of all, I want to thank everybody for having me. As a scientist, it's really important to say two things before I answer that question. The first is the Centers for Disease Control and Prevention have not released new statistics on maternal morbidity and mortality since 2007. And there's a variety of reasons for why that has been, including the funding of the federal government for health services research. So we believe that the numbers that we see, that there are 700 to 800 deaths per year, and those are disproportionately borne by Black women, is an underestimate. And so I just like to put that out there. The second thing I want to be able to say is that we also know that there are estimated to be about 50,000 what we call near misses. So people who need things like blood transfusions, people who need to have their uterus removed to stop bleeding, they don't die, but they're near misses. And so I need to contextualize the statement that I'm going to say. So in thinking about the number one causes or the top causes that contribute to maternal morbidity and mortality in the United States, specifically related to pregnancy, we usually hear cardiomyopathy, which is diseases of the heart, whether it stems from chronic untreated hypertension or high blood pressure, and then you think about hemorrhage or bleeding out. But one of the interesting things that never comes out in the statistics when we talk about maternal morbidity and mortality is that 60% of these deaths are considered to be preventable. So there's actually some hope that there's something we can do about it. So whether it's the combination of cardiomyopathy or hemorrhage, too much bleeding, or if it is some other comorbid condition, paired and coupled with implicit bias or structural racism, and people ask me all the time, how does that show up in health services provision? I always say, well, you know, if you don't listen to people and don't believe them, you might be in a position not to be able to recognize the signs and symptoms of deterioration. You might miss some very key things that you need to hear in order to be able to know that someone's going downhill quickly. And so there are different ways to think about it, but cardiomyopathy and hemorrhage, two of the most common reasons why we see maternal mortality are treatable, and most of those cases are considered to be preventable.
And there's also a bias, especially with, I think, Black women or women of color in general, that we are able to tolerate pain more. So therefore, does that fit into it?
Totally. And I also think there's a narrative that we come to pregnancy older and sicker and fatter. And that's just not true. One of the reasons I wanted to do the data visualization project that I did with Scientific American in May to actually show high income countries or similarly income countries, even when they have the same trends towards obesity, even when they have the same trends towards hypertension and diabetes and pregnancy, even when you see older moms, when you see those exact same trends, they don't have the same proportion of maternal deaths as we do in the United States. So it can't just be the older, sicker, fatter narrative. There are other things that are going on that are really, really contributing to these deaths. And again, they're preventable.
They disproved this narrative with a crucial study in New York City, where they did a study of the women, maternal mortality of who died in New York City. And they discovered that educated, not poor, Black women died at a higher rate in New York City hospitals of maternal mortality than poor, uneducated white women. So it's fictitious, basically, the whole thing.
And then there was another study, I guess, out of the University of British Columbia, and what were the findings with that?
So I've been lucky enough to be involved with a multi-center, multi-site group that has just completed a study. In fact, it probably should have dropped at 2:00 today Eastern time. That's the largest survey, quantitative survey, that's community engaged, community informed, looking at patients' experiences of birth, pregnancy, as well as postpartum. And we got 2,800 responses to that survey representing all 50 states. And as a nurse, I've been a nurse for 30 years, right? These results and these findings are extremely depressing. They look to everything from disrespect and mistreatment. We've asked very specific questions about coercion and informed consent. And it's across the board. All hospitals, all health systems, there was no specific one place, and we purposefully oversampled for Black and brown women and people of color. And we found overall that there is some mistreatment that's going on. And that's a lot of complex factors, right? We don't have a national health service or a single payer, so that we have disparate places in where, we see funding for health services provision. You have, shortness of staff. You have lack of access in rural areas. So, half the births in the United States are covered by public insurance, or what we call Medicaid. Half the births in the United States, right? So as taxpayers and individuals who are invested in maternal health care, we should expect to see better outcomes. And so I do think that from our study, the data, it's the largest survey. It's called Giving Voice to Mothers, largest survey of patients' experiences of birth and maternity care in the United States, and it's shameful.
Well, going back to what Amy was saying, coupled with that, I mean, we have an example of just listening to your patient, right, with just Serena, who has all the money in the world and had a known medical condition, and still wasn't listened to when she was trying to tell them that she was short of breath and might have a clot in her lungs and needed a CT and heparin. And after telling her no and stalling, guess what she needed? A CT and heparin. So Charles, what was your interaction with the staff in the hospital? I mean, was there anything that they did to give you support or offer resources or anything like that?
No.
Short answer?
Short answer. So the abbreviated experience was we went in at 2 p.m. for what was expected to be a routine scheduled C-section. Recognized, as I mentioned in the video, that Kira was bleeding. Actually, I was the one that recognized it. I was the one that noticed the blood in her catheter. Brought it to the attention of the staff at Cedars-Sinai shortly after 4. They came in, they assessed her, did tests, including a CT scan that was supposed to be performed stat. And when I say stat, what does that mean for everybody in here? Immediately, right? So bring it to the attention of the staff at Cedars-Sinai. At this point, I'm concerned, but I'm like, we're at Cedars, my wife is healthy, my baby is healthy, we got a plan, I can work with this. The very condensed version for the interest of time is that Kira was allowed to bleed internally and suffer for almost 10 hours, while myself, my family, Kira's family, all begged and pleaded for the staff at Cedars-Sinai to take action, right? And sat there and begged and pleaded and asked, when is the CT scan coming? And they say, it's coming, it's coming, it's coming. When are we taking her back to surgery? I'm not really sure. It's coming, don't worry. And hours are going by. Kira's condition is continuing to deteriorate. 6 o'clock, 7 o'clock, 8 o'clock, no CT scan. If you look at the medical record, she was classified as a surgical emergency at 6 o'clock, 6:40, I think. 9 o'clock comes, 10 o'clock, 11 o'clock, 12 o'clock comes. It wasn't until after midnight that they finally took Kira back to surgery. And as the team at the residence, just the way they captured that scene, and so finally they take her back to surgery. It's after midnight. Walking down this hallway, and I'm holding her hand just like you saw, and I'm telling her everything is going to be okay. The doctor's level of concern, his sense of urgency for my wife never elevated. He said, just as I said in the video, she'll be back in 15 minutes. These things is not a big deal. I'm going to find out what happens. She'll be back in 15 minutes. When they opened Kira up, there were 3.5 liters of blood in her abdomen. And we're talking about a woman that's 95 pounds on a good day, right? And her heart stopped immediately. There was nothing they could do to bring her back. And we spent a lot of time, and I'm so grateful to Chris and Tiana and Amy. How long did we sit in the room with you guys? Probably at least hours. And I told them, yeah, and you can see these details, these nuances they picked up. And we talk about support. There's so many layers to this. There's the layers of clearly serious neglect, bias, implicit and otherwise. But then there's also, in our case, and as you saw in the episode, the parallels is this lack of fundamental human decency. And for us, when we got the news, the doctor that was responsible for Kira's care never came out and gave it to us. He sent the residents, right, along with a trauma surgeon who we'd never met before, which is representative of Malcolm's character, right? Who was brought in to save her when this doctor came over his head to give us the news while he slipped out the back door, right? And so,
That doesn't only happen to African Americans.
right, yeah, it doesn't.
That happens to a lot of people.
It does happen, but it definitely happened in our case. But the totality of it, and I have to ask the question is, would that have happened if I was not African American? And I think that the thing is this, is that we see across the board, whether it is, Shalana Hazard, whether it is Kira Dixon Johnson, whether it is Serena Williams, there's a fundamental, there's a lapse, right? And there's this inability for the people that are being trusted with the lives of these precious women to see them and value them the same way that they would see their mother, their sister, their daughter, right? So there's also this lack of just humanity and compassion that is causing women to fall through the gaps and suffer catastrophic and sometimes fatal consequences.
I saw a video where you were talking about how you didn't want to be perceived as the angry Black man so that you would not get further, not care. So that was part of your journey?
It really was. And so briefly I'll tell you is that, this was supposed to be a walk in the park for us. We've been through the overbuying, the over-anticipating. We're pros at this point, right? We're going in for a scheduled C-section. We've got the bag packed. I've got my sweats. Kira's got her sweat. Comfort and function. That's what we're thinking. We're going for the hospital for a couple of days. We'll be out. The night before we went into the hospital, Kira's in the mirror and she's combing her hair. And she says to me, baby, I want to look really pretty for Langston tomorrow. And she goes in the closet and she picked out a dress and she picked out all her jewelry and everything that she was going to wear. I, halfway joking, said, man, let me get my stuff together. Because you never know when you need to look like you have a little bit of money and a little bit of sense. I went in the closet, I picked out a button-up shirt and some slacks and some loafers. So even unknowingly and subconsciously as an African-American male, I was already conscious of the way I would be perceived in the event that something happened. So fast forward to 12 hours later when my wife is literally fighting for her life. And this is the thing that haunts me now. I think maybe, what if I had raised my voice? What if I had slammed on the counter? What if I had grabbed a doctor by his collar? But the entire time I was thinking, I've got to stay calm. Because if I raise my voice, then as an African-American male, I become seen as a threat. And exactly, and as difficult as this is for me every day to live with, I think about, and when I think about those things, I think about, well, what if I had been kicked out? And then the same result ensued. I would never be able to live with myself, and who would be there fighting for my wife, right? And so there's all these layers that as an African-American man and as African-Americans or minorities, we don't even have the latitude or the autonomy to express ourselves when it is the most critical situation, right? And the people that depend on us, I didn't feel like I had the ability to fight for my wife like I really felt like I should have, right?
And Monica, we were talking about this in the back about the nurses being more about their safety. Can you talk a little bit more about that?
Actually, Karen was talking a little bit about that because
was that Karen?
Yeah.
Go ahead, Karen.
No,
Sorry.
I mean, listening to all of you all talk about it is the fact that we have technology, right? We have technology, we have toolkits, we have bundles. There are, if 60% of the deaths are preventable, and we have trainings, we have simulations that are going on in our hospitals in California and in the nation, it's not that we don't have the technology. We just lack the ability to see Black births and Black women as valuable. Like we have hospitals, when we talk about structural racism or even implicit bias, but I really believe it's structural institutional gender racism where we have framed mothering or birthing for one way, right? There's one way to be a mother. There's one way to be a woman. And when we hold those scripts, those narratives up to how we provide care, then the delay, the dismissiveness, the disrespect is because we fundamentally don't see Black people, Black mothers, Black births, we don't see them as human, right? I mean, we have tools, we have toolkits. I mean, in California, we are leading the way. We've been able to reduce our maternal mortality by 55%, but for a couple of groups. And that group does not include Black mothers, Black birthing people. And so the fact that we're still dying at the same rate now as in 1999, despite the fact that, again, we have toolkits that address hemorrhage, cardiovascular disease, supporting vaginal births, but why are Black women and Black birthing people leading as the group, although the population of Black people in California is 4%, but we're leading in the death or near misses and complications, and also in cesarean births? Why is it that when we see a Black woman who, again, that trope of that narrative of a Black woman who's older, sicker, and fatter, we automatically judge to thinking, well, are they the welfare queen, or are they lazy? Are they unintelligent? The fact that you already knew that you had to adjust yourself a certain way to not be perceived as the threat, that also happens with Black mothers and Black birthing people and the families that come to the birthing space where the staff is more concerned about their safety. And I've learned from Monica that when we think about patient safety, it's really safety from whom? Because it's not really the safety of the patient, it's being the safety of the system. And so how do we reimagine, redesign care that says that there's no default human? We talk about that a lot, right? Like, how do we evaluate the ways in which we are responsive and relevant to Black women, to Black birthing people, to Black families? And so it comes up a lot, right, in the ways in which care is administered or not administered, and who gets the room by the OR. Like, if you can be of a certain class, a certain affluence, a certain marital relationship status, and when you walk into the hospital, you're already asked, what room do you want to go to? I've never seen that for Black mothers and Black birthing people, but I see it for other particular ethnic group that has power and autonomy from the moment they walk into the lobby, the greeting, right? Who takes you to the elevator, security, or do you get to go yourself? I mean, all these things that are happening when people are coming to the hospital, right, to celebrate something that's birthed, that could be seen as an act of resistance or resilience or just joy. We strip that away from them on top of their humanity.
Well, and piggybacking on that, talking about what we were talking about in the green room, just the idea that we limit the number of people who can come into a birthing space. I mean, one of the things that we were talking about that I thought was really fascinating for me, and I'm glad you illuminated this, was, if your staff are primarily, white, or if your staff are primarily subject to implicit bias, and they perceive a group of Black men coming in to support a Black birthing person as a threat, then you can argue that they will spend time at the nurse's station. I'm a nurse, so I'm gonna represent the nurses. You can represent your obstetrician peeps, right? But, they will answer your call bell from the desk. You can monitor a fetal heart rate from the desk. You can monitor vital signs from the desk. You don't have to go into a room. And so if you have either an explicit bias or an implicit bias against or towards a group of people, you may be slow to enter a room. You may be looking on a monitor and saying, oh, wow, that looks okay, not really observing what's going on with the patient in the room. So again, going back to the way we set these systems up, the way that we think through how responsive we are, right? These are both explicit and implicit biases that are structurally located that can actually be fixed.
And I do want to add to that, I'm a recovering OBGYN. I say that. No, I'm serious, because I have to unlearn the fact that I, as a Black woman, was trained, I always akin the healthcare system to law enforcement. We racially profile. And in Morning Reporter and sign-off or handoffs, the very way I describe, again, the Black woman, I don't even have to use race, but the way I've been trained to talk about her to my peers sets the tone, right? Sets the narrative, creates the scripts for how the remainder of the staff will respond or not respond to her. So we do the same thing. And so again, we have framed the stories of how to devalue and degrade and demonize and pathologize and criminalize birthing while Black. And we have to shift that. And so again, we have systems that have been trained to recreate conditions that allow for this to happen. The data's been there. I always talk about, we have surveillance systems that existed to record these numbers, but our communities have always been the repository of stories when people don't come home from the hospital, right? We've been holding that loss for decades. And it's only now are people wanting to listen to and value our stories, but our communities have known that these deaths or near misses were happening, because that's how we figure out sometimes which hospitals to go and not to go to.
What we were told when we made the episode by the experts we talked to is the speech that Belle gives at the end, which is Devon, who is also subject to implicit racism in the episode and is Indian, goes and tells the head of the hospital, this is what you could do. And what we were told was, and I'd love your input on this, is that systems don't exist for mothers. In other words, if you come into the ER and you have chest pain, there's an immediate protocol that must be followed that is supposed to, and hopefully does, subvert any bias, because I'm, this day and age, not feeling hopeful about getting rid of racism. I'm feeling really bad about it. So how do you overcome it? So the idea is that, okay, you come in with chest pain, you have to have this within a certain amount of time, and this within a certain amount of time, and this within a certain amount of time. So had that, and there is no system of protocols for mothers after birth. So for example, if there was one, there's blood in the catheter, automatic CT, right? Then you don't have to, why should you have to be advocating for it? It should be a protocol that's in place. If there's a drop in blood pressure of X things, these are signs of internal bleeding. It's not, you're supposed to, can you take out the human factor with those protocols, or would that not work? That was what we were told they were trying to get done.
So that is, I think, and I'm certainly not an expert anywhere to the degree that these wonderful sisters are. But let me say this. When we talk about Kira's case in particular, in the case of several other women, we talked about these hemorrhage bundles and how California is the landmark state for the impact that, introducing postpartum hemorrhage bundles and cardiomyopathy bundles have, the way they've utilized it to reduce the maternal mortality rate is second to none, and California leads the nation. However, at Cedars-Sinai, they had all these bundles available.
And they didn't do it.
But what happens is when these bundles are a suggestion and not a mandate,
yeah, they have to be a mandate.
They have to be a mandate, and there's not a standard, a fundamental standard of care that is mandated, like you said, there is in the OR, then implicit bias, like you said, can creep in. And literally, she sat there and bled for 10 hours when these toolkits when all these resources are right there at her disposal, right? I didn't know about them, but the thing is, like I said, if there's suggestions and not mandates, then women can fall through the cracks. And so that's one of the things we're fighting for.
There should be mandates.
And that's one of the things we're fighting to make sure happens.
But I also think I agree with everything that Charles said, but there's two other points that I would like to make. Number one, the bundles were not optimized across different races, different ethnicities, different ages, different, nuanced pieces. Again, Karen said this probably more implicitly than I'm going to say it, but I'm going to be a little bit more explicit.
Please.
There are no default humans that serve as a standard for the rest of the population. I know that makes people crazy when I say it, but there are no default humans that serve as a standard for a population. So, and what I mean when I say that is, communities have to determine what is most relevant, what is most important to them. Now, am I saying that postpartum hemorrhage is going to look different in one population versus another? No, but what I am saying is that we still need to be able to understand informed consent. We still need to make sure that social support is available. There are a whole variety of other things that we need to make sure are in place so that we don't just adopt one standard that works for one group of people, because as Karen said, as much as the postpartum bundles and the hemorrhage bundles have really worked in California, we still see a very high Black maternal health rate. And so there are places where we need to optimize where bias currently exists in those bundles, and so that we can ensure that action and activity follow up in the context of the bundle, so that there is an appropriate urgency that occurs in the context of the bundles.
And I want to add to that, saying that, again, we have to, clinicians need to know the data. So the way you describe the data in New York City, we have California data. We have data that shows in our state, Black women who have a level of affluence, social economic affluence, relationship status, higher education, insurance, still have worse outcomes than white women, teens who have less than high school education. So once we destroy this narrative that it was me as a Black woman, like my body is the reason why I die in birth. Like it's me. It's my fault, right? It is the mother blame. Once we disrupt that narrative of structural racism, mother blame that says it's being fatter, older, and sicker, then your story, and thank you for sharing, like it shows that it's not those things. The majority of things are happening because of a lack of responsiveness. And even if the leading causes are cardiovascular disease or hemorrhage, again, we have the tools to do something about it. So why do we continue to dismiss, to ignore, to minimize pain, shortness of breath, and fatigue from Black women and Black birthing people? Because people are speaking up. But what is the responsiveness of the system? So you can have these toolkits, but if you say they work and the hospital is only doing it for one group, we have to really examine and critique why is the system only responding really well to one group. And even when they see their numbers, right? How do we look at data across various races? But again, not looking at race or ethnicity, but systems of racism or gender racism and how that's impacting the way we see people and how we respond.
And I think, bringing up this issue of pain, you asked the question, I didn't answer it directly when you asked it before, so let me answer it. We still have been petitioning for schools, and I'm at the University of California, San Francisco, right? One of the top medical schools, top nursing schools, pharmacy, dentistry in the country. We still have textbooks that teach that there are differential experiences of pain. I mean, we had a study that was published 2 years ago, University of Virginia, that showed that medical students actually thought that Black people didn't experience pain in the same ways that people of other races and ethnicities do. So if that is the foundational knowledge that you have in human assessment, no checklist or other bundle is actually really going to eliminate this idea that you don't have to be looking for something that you don't think those people experience. Right. Does that make sense? So that's why it's more nuanced than you can't just have a standard checklist if the fundamental beliefs that the checklists are based on are incorrect and inaccurate for a whole segment of the population.
And along with these bundles, are they actually doing training when they put these bundles in? Is that part of the protocol?
So yes, I can speak on that. I mean, so for example, if we look at, I think, the obstetric hemorrhage bundle, so looking at that phenomenon and its contribution to severe maternal morbidity or near misses, out of the 126 hospitals that participated, they reduced their near misses by 20%. The hospitals that did not implement only reduced it by 1.2%. So when you use it, it works. So the question, again, is not about Black women, something's wrong with us. There's something biologically inferior to us. And it's not that we don't have the checklist. Why are we not using them on Black women? Just to be very, why are we not utilizing them to their extent? And when we do use them, it's too late. So again, if people fundamentally believe that when we show up, there's something already wrong with us, that even if people do intervene, it's not gonna get better because there's something innately wrong with us, that's the thing, is how do we break that script and that mode of what's driving the provision of health care services, but also the way health services research is conducted. Because we have people looking at the numbers and telling stories off of statistics without the appropriate analysis that looks at us through a lens of being humanity or a lens of reproductive justice. And so again, you have multiple systems contributing to the design and the operations of our birthing systems, our maternal health care systems in the US.
Which I think is why it's so important for it to put a face on it, like Charles's organization does. Because then you scroll through the statistics and you put that face, and then people understand that this is their mothers, their wives, their sisters. And so getting back to The Resident, that is set in Georgia, which has one of the lowest mortality rates.
It has one of the worst mortality. Highest.
And by lowest, I mean highest.
Right. It has one of the highest maternal mortality rates, yeah.
Does the state have any plans to improve the quality of maternal care? I mean, obviously they don't.
No, they don't.
But do they have any does anybody know if they are working on that?
So Charles and I, we're at the Georgia Perinatal Equity Collaborative, and we can explain what that is if you don't know what that is, but states have been incentivized to develop cross-sector public health discussions between clinicians and scientists and scholars and payers and funders to really be able to improve quality of care within healthcare providing institutions in the state. And one of the things that's really hard about Georgia is we have a lot of colleagues and collaborators doing reproductive justice work. In fact, before Karen and I came, we were on a national call with Sister Song, which is one of the leading reproductive justice organizations and voices in Georgia. But you're right to point out that the maternal health outcomes in Georgia are some of the worst in the country. And like many states, they have been passing very restrictive laws across the reproductive spectrum, but specific to abortion access, specific to contraception and family planning. And so when you think about it, I know for me as a public health nurse, a clinician, and a scientist, it's very difficult for me to tease apart the entire reproductive spectrum of individuals, because for Black women, that is an experiential, very important part of their lives. And so for me to think about achieving real reproductive justice, not only is it dismantling the narratives around structural, interpersonal, and institutional racism, but it's also really being able to affirm that people can create family and create kin in whatever ways that they see fit, and they have the supports that they need in order to be able to do so. That if they need to prevent or end pregnancy, they have all the tools that they need in order to be able to make that happen. That they have the freedom, the autonomy to be able to parent the children that they have with dignity, free from violence, manipulation, coercion, from any individual and from the state, by the way. And I would also state that people have the right to disassociate sex from reproduction, which gives us a platform to talk about consent, healthy sexuality, and pleasure. Those are the tenets of reproductive justice, and there are people doing reproductive justice work on the ground in Georgia, but unfortunately, their legislature is not listening to them. Charles, you said something that was really important at the March for Moms, and it really talked about there's no path to the White House. Would you please share that with the audience, because you said it better than I will.
Oh, yeah. So here's the deal. Let me talk just a little bit about my state of Georgia. So for those of y'all who don't know, Georgia is home for me. Kira and I are both from Georgia. We had actually only been living in Los Angeles for about 6 months before this happened. And so I'm back in Georgia now, raising our 2 sons. So the show is set in Georgia. Let me talk just a little bit, add something additionally about how being active, all politics are local, right? And how this trickles down and impacts people's everyday lives. Right now, and my people who are watching in Georgia, forgive me if I don't hit this right on the head, but right now in Georgia, I think it's 70-something out of the 160-something counties in the entire state do not have any obstetric care whatsoever.
72. Oh, that's correct.
72, right?
Yep, that's correct.
Right? And this is a direct result of slash in funding from the federal government and rolling back, the ACA, right? So there have been consistent closures. So what does that mean if you are in rural Georgia and you have a pregnancy, let alone a high-risk pregnancy, and you're assigned to a specialist, and now you have to drive 2 hours just to see your specialist? One, can you do it? 2, can you afford the gas? 3, do you have to make difficult choices between work and seeing the specialist, right? So all these things trickle down. So let me get back to what you were saying at the March for Moms, and we were there, and I was honored to share the stage with you last weekend at the March for Moms. And here's the deal. There's so many constituencies in this country, but the reality is that people in this country who care about mothers and babies are the largest constituency there is. Because there are 2 types of people in our country. Either you are a mama or you got one, right?
Right. Say it, Charles. Say it.
Right? So there's so much more that, that brings us together than it divides us, right? And so through the help of, this show, through the opportunities we've had to share this crisis, people are waking up and they're understanding, regardless of where you sit socioeconomically, where you sit from a racial standpoint, mothers and babies are in crisis in this country, and it's more expensive and more dangerous to give birth to a baby in this country than ever before. So what I said, then I'll say here, is that there is no path to the White House in 2020 or beyond without a clear, comprehensive plan for what you are going to do to address the maternal mortality crisis, okay? And if you guys have been keeping up, right now, Senator Gillibrand has introduced a maternal mortality bill. Cory Booker has introduced one. Kamala Harris has introduced one. Who else am I leaving off?
Robin Kelly.
Robin Kelly has introduced one as far as presidential candidates. So who else do we have on the president that's running? Elizabeth Warren, that's very aggressive. And honestly, before November, Bernie Sanders actually is working on one. If I stole your thunder, sorry, Bernie. But he's working on one. And so before November, I feel that every single presidential candidate will have introduced one. And if they haven't, they're going to have to answer serious questions of why they have not. So if you are planning to sit in that seat in 2020 or beyond, show up with a plan or don't show up at all. You got to come see us, right? We got to come see people in this country that care about the well-being of mothers and babies. Show up with a plan or don't show up at all.
Yeah. Do any of the Republican colleagues have a plan?
So I think that, quite honestly, and that's everybody. I don't care what party you are. You at the Republican Party, Democrat Party, Tea Party, After Party. I don't care. Like, show up with your plan.
After party needs
right?
a plan.
So the after party, the after party.
They need a plan.
So and honestly, I think that President Trump is going to, and I'm anxiously waiting to hear what President Trump's plan will be to address this situation.
He did sign, sign a bipartisan bill in December that was sponsored by Butler Herrera, and it did get signed. So to be clear, the Preventing Maternal Death Act was passed in December, and it was signed into law. Here's the thing, right? I mean, for people who are watching, for those of you in the audience, we have had, and Charles was absolutely right, 72% of counties in Georgia do not have an obstetrical provider. But how many people in this room know that 90%, 90, of the counties in the United States do not, total, when you add it all up, do not have obstetrical providers? Yeah, it is a huge number. We do not have the workforce that we need in order to be able to support birthing people. So I would be remiss if I didn't shout out the Black Mamas Matter Alliance, because I think it's super important. I can't believe I talked about Georgia and didn't mention them. But one of the things that the Black Mamas Matter Alliance has done is to really catalog where, within the Affordable Care Act, you mentioned that, where states expanded and did not expand. This is how we know. They've compiled statistics from HRSA. We just had our successful Black Maternal Health Awareness Week, and Karen and I sit on their advisory committee. 90% of the counties in the United States, when you add them all up, do not have obstetrical providers. Now, let me juxtapose that statistic with half the births in the United States are covered by public insurance, by Medicaid. So we're citizens, we're taxpayers, right? We have the opportunity to be able to tell new narratives about the strategic and key investments we need to make. I said this earlier in the back. Maternal child health, the health of birthing people, these are barometers that we use at the World Health Organization, United Nations, to know the well-being of your country. Yeah. Right? If we can't take care of the healthiest people in the hospital, and generally moms and babies are that,
yes, they are.
Something's wrong. Our priorities are messed up, right? So we really need to be thinking through what investments are we going to be demanding so that we can actually turn this crisis around. We know 60% of these deaths are preventable. So as long as that's true, what are we prepared to do?
Please let me just say something to that. And I want to definitely shout out BMMA. And as Monica was saying, we also need to ask you all, holding our government and our systems accountable, let's diversify the workforce. There should not be a supremacy of medicine. Like my peeps, thank you, but we're specialized to do specific things. Most of the time, you could exist with the doula and the midwife. So I just want to lift up that we need to diversify and be more inclusive of who the birth workforce is. Right? Yeah. Because we do. Yeah. Because I was trained, as I say, I was trained to manage birth. I was trained to manage birth because of time. I have other things to do. Then when I was a full scope general GYN, I did obstetrics and gynecology, office, inpatient, outpatient. I have had to delay surgery of an hysterectomy to go run to the floor, to go do a birth, to facilitate the birth and support, then run back. Who wants that as the person supporting them? Whereas midwives, and particularly doulas, I said they move with bodies and time. I can't move with bodies and time. I wasn't trained to. But if you can support those folks who can actually be with people, hold space with people in birth, then we could have someone at the bedside that actually radically loves them and supports them and listens to them and advocates for them to be able to say, hey, come out from the station or come from the board there and come into this room because these things are happening, so that families don't feel the pressure of having to navigate that power. So there's opportunities to redesign maternal perinatal health system. We need you all to raise your voices and demand that.
And I think I was reading one of the things that we're trying to do is make Medicaid for longer because it only covers for a certain amount of time. Because I was interested to find out that these statistics that 31% of the deaths occurred during pregnancy, 17% the day of delivery, 19% 1 to 6 days postpartum, 21% 7 to 42 days postpartum, and 12% 43 days to a year postpartum. So that's got to be added into the care.
So for people who don't know, if you are not lucky enough to have employer-sponsored health insurance in this country, I've stopped using the word private because that's not what it is, right? We have employer-sponsored health insurance or we have public insurance, right? If you have public insurance, your baby is automatically covered and you lose your coverage after 60 days. So many of the bills that we hear from the presidential candidates actually suggest there are things we could do right now. We could expand Medicaid for the birthing person for a year, right? We could do that like right now. So to think that there's not things that we could be doing, I think is a little bit disingenuous. But the idea that a birthing person, and we have so many workarounds as a nurse, we usually tell postpartum people, make sure you get your glasses and go to your dentist and do this and do that, get your medications filled and do this and do that, because we want to make sure that they get the things that they need before their public insurance runs out, because they're only eligible for it during pregnancy. Right? So at some point, we're going to have a conversation about appropriately ensuring people with the capacity for pregnancy so that we get the things that we need, whether we're pregnant or not. But that's a different panel.
Amy, what kind of response did the story get after it was aired?
The overwhelming majority of the response was very positive. We try to say something with the show, but we try to entertain when we say something with the show. I always say we put the pill in a candy wrapper, and nobody's going to take it otherwise. So it's not like watching episode 220 of The Resident is a difficult or painful thing to do. I think it's actually our highest achievement, and it is highly entertaining. And so the majority of people responded to that. I'm horrified to say that not everybody did. There were comments on fan sites that were negative and that accused us of being racist to whites. And that really did break my heart. But that's the society that we're living in right now. And it was not our highest rated episode. It's our best episode. It's not our highest rated because of those elements. And I think it will last over time and be viewed over time on Hulu and Fox.com. But, this is explosive territory at the moment. And, I don't have as much cred to speak on this panel as all of you do. But I do want to say that this is a problem that is for white mothers also. It is much worse for black mothers, but it is for poor mothers a great problem. There was a story that stuck with me forever of a woman who had a C-section and was sent home and was poor and was with her mother. And I believe she was white, and started to have terrible complications and a fever a week or so in. And they kept trying to deal with it because they didn't have the money to go back to the hospital, and then it got urgent. And this is a true story, and the mom called for the ambulance. Ambulances are privately owned now. Yep. And an ambulance can cost you thousands and thousands of dollars.
Yeah.
So 2 ambulances of these private companies showed up and ascertained the woman was poor and ascertained she didn't have the money to pay for that ambulance. and they both left. And she died.
Yep.
So the problem is even bigger than racism. The problem is money too in medicine, and this horrible, when you say that these things should be paid for, they scream socialism, and it's not. Somehow Medicare is not socialism, but for all the rest of us it is, and it crosses lines horribly, much more for Black women into. If Serena Williams cannot be listened to, then who the hell is going to not be listened to? If Kira cannot be listened to, then who is not going to be listened to? But there's also the issue of money in medicine. There is definitely there.
Monica and Karen, do you guys have any stories that you'd like to share of similar instances?
So one of the things that I do, I still work as a nurse at San Francisco General Hospital, and one of the things that really sort of makes me crazy is when we have birthing people that we know we would like to be able to keep in the hospital, going back to this payer situation, but that we know that we're balancing this very strange equation where if we keep them longer than what their public insurance will cover, we know that they will be billed. And so then we're in a situation where they believe that they would rather sign themselves out because they can't afford to stay, right? I mean, this is the United States in 2019. I work at a public hospital in one of the richest cities in the country. So I think we need to have a really hard conversation about healthcare financing. I've written about this and I've published this, so I don't feel bad saying this, but we need to call out the states that didn't expand Medicaid as unethical, because we know that the moms and the babies who live in those states where Medicaid was expanded have better health outcomes. And so I really think we need to have a conversation about healthcare financing because, it is difficult to balance. We want to send you home, so that you don't receive some huge bill. And at the same time, it might not be time for you to go home. That is not what I went into nursing to do.
The other thing is that it's possible to do, because what happens in the American system is that those privately insured and the rich are actually overtreated and harmed. And they are over-tested, they are given too many procedures, they are given too many stents, they are given too many tests that could kill them. And all of that money is wasted because they're giving too much that harms. If they weren't doing that, there's plenty of funds left to insure everybody to a decent degree, instead of chasing, the fabulously wealthy who come in and who will pay the most, or the insured who will pay the most.
Part of the reason that I didn't mind leaving emergency medicine, the practice of emergency medicine, was because I always felt like we were having to rob Peter to pay Paul. Like it was always like this person comes in so we can pay for this person to get a modicum of care.
Yes.
Yeah. I do want to share a story, but with the context or caveat that, only 2%, I believe that's the number I learned. 2% of all physicians are like Black women OBGYN. So my stories can be connected because there are not many of us, as Monica always tells, there's not many of us who are physicians and nurses who are Black in California. Is very different when you're in Chicago, Atlanta, and DC. Let me just say that, where there's more of us who can work together on the unit. One of the stories that I always think about that makes me once again, if we actually just had more compassion and patience with Black women, right? And there's one of the stories where a Black woman was pregnant, went to a routine prenatal care visit, did some testing, surveillance that they did, which is right, appropriate for some things, found out something at that visit, right? So if you come to your prenatal care visit, you think you're going to be out and go home. But she ended up being asked to go to the hospital, right? So there is some consent in that. She went to the hospital, but then as we're rounding, and I say myself as I'm a hospitalist now, so I focus only on inpatient care of people who are pregnant. And in rounding with her with the specialist, a maternal fetal medicine specialist, she now had to be hospitalized probably for the duration of her pregnancy. And I think she was right around 25 weeks. So you don't think that when you go to your prenatal care visit that you're going to be asked to hospital, you need to go to the hospital right now. So we think about informed consent. It's information, comprehension, and voluntariness. along that spectrum, particularly Black women, those rights are being violated. So when you're at the hospital and you're like, I don't really know why I came here, they just told me to come, I'm staying. Well, the other side of the story is that she had gotten into a car accident. That was not the reason why she was admitted. That's another sideline, that's another storyline. Had been in a car accident, had rented a car, which was now in the parking lot, right? Metered time. Did not have the money. So she's like, I just need for you to let me leave the hospital to get that car back to the rental. I will come back. I'm like, oh, girl, I got you. I trust you. I believe you. I don't think you're running a game on me because you're a Black woman telling me this. Well, I got into a big altercation. And that's to say it nicely, with the charge nurse. But because she's like, those people, you know, when they leave, they're not coming back. Those people. And I'm so used to being spoken to like that as a Black woman, OBGYN, advocating, fighting for Black patients, that I would just went back and I'm like, you know what? What you're saying is like, it's so unethical and inappropriate. She left all of her things in her room. You are willing to add stress to her life for charges from possibly getting towed, right? Being in the parking lot. She has to figure out how, if her job that she has, probably 2 part-time jobs, which means she doesn't have benefits, is she going to get paid? Like, there are other things that we're grappling with, and the system negates our whole lived experience. And so the chaplain, who's a Black woman, and I love her and thank you, heard the interaction, was just like, come here. First, she hugged me, affirmed me, pray for me. She said, I'm writing this up. But like, these are the things that we go through as Black women physicians advocating for our patients, because the staff people are saying, well, you know, I'm going to write you up because you let her leave. And I said, I can't believe, do you know the circumstances of what's happening to Black women who are pregnant and birthing? Why are you not trusting her to come back? Why are you not believing that she cares about her body and her baby and that she's willing to do all that she can, which means she can't afford to not have money right now. So let her leave, handle her stuff, because it was safe for her to leave. That's the other thing. Me and the specialist, like, you can leave. You're not bed bound. You're just hospitalized. Doesn't mean you're bound and chained to your bed. So I just wanted to tell this story. Is like, there's a lack of humanity and dignity. There's a lack of believing that Black mothers care about themselves and their lives outside the hospital. So how do we work in the context of their lived experience? Because they're doing that when they're making decisions. But the hospital is so arrogant to think, well, it's just about us right now. No, it's about their whole context of their life and the other things that they're responsible for. We don't know that, Black women are usually caring for other people. And so how does the system who says now you have to be hospitalized or now you need this treatment negates the fact that we have so many other things that we're dealing with that just give women patience to figure it out and trust that they will do what they need to do?
Well, we have a 3-minute warning, so I really wanted to go into, when you were talking about the diversification of care earlier and you were talking about the doulas, I thought you were actually going to go into women, doctors of color taking care of people of color. Mm-hmm. And so I think that is obviously one solution, one way we can help this system. Can we talk about some other solutions that we can move forward with?
I personally think that we need to move to new models of care. So diversification of the healthcare workforce is one of the low-hanging fruits that we could do, along with expansion of people's insurance time. But we need new models of care. So we need to be able to have patients to have group prenatal care, right? To learn from each other, peer-to-peer education and teaching. We know that group prenatal care provides superior outcomes in certain populations, specifically African-American individuals. We need to be.
How does that work exactly?
Group care. So what it is usually
She's
people.
planning episode 310.
Let me tell you. Full disclosure, I sit on the Centering Healthcare Board, and Centering was the first group prenatal care model, but there are others, Expect With Me, and there's a whole group prenatal care demonstration project in Fresno that the Preterm Birth Initiative at UCSF is running. What it is you get 8 to 10 individuals who have the same estimated due date, and they visit for much longer appointments, usually between 90 minutes to 2 hours. And they all will do their own blood pressure, their own vital signs. They will dip their own urines. If they need a private confidential visit with the clinician, they will go behind a screen or in a different room. But otherwise, they sit in a circle and they all learn from each other. There's a curricula, whether it's around nutrition or physiologic changes. If the group is diverse enough where you have people who've had babies before, people who have not, it's very, very helpful, but it creates a social network.
Are these clinics and practices doing it or hospitals?
Both.
It's both.
Both.
Fabulous idea.
Can I also add to that? We need
Hello, guys. Out there.
we need patient or community driven ways of evaluating these practices. And so we've been taking care of ourselves for centuries, right? Grand midwives, I want to applaud them. Things were stolen, repackaged, and made for one group. And we need to bring back the fact that we've always been caring for ourselves. So what would it look like if the community was driving the provision of the services or the design? Like Monica does at least with this, what would it look like if the community actually told the system, this is how we want to be cared for, right? This is what we want our pregnancy or our prenatal care to be like. What would it be like to have a community-driven IRB, which is basically Internal Review Board, the people who evaluate research, the ethics of the way research is conducted. But are they from the community? So what would it be like for the community to define what the ethics of prenatal care would be, right? What would it look like for the community to define the very variables that payers and credentialing companies use so that we actually value the community's definition of a variable and its meaning and its measurement? So we're not just looking at preterm birth, low birth rate, or death. Maybe it's joy. Maybe it's joy defined by Black women, Black birth joy. I think we really need to come to the community in the redesign of healthcare systems.
Yeah.
And then and just on an individual basis, as when your mother's, I guess your mother, sister, wife is going into the hospital, what are things that they can do to help advocate for themselves once they're there, or even in the pre-birthing process, picking the hospital? What are some things that individually we could do when you're about to have a baby?
Well, I think the royal family just showed us a really important piece of that, which is have your birth plan. If people want to laugh at you, ignore them. Have your birth plan. I would also tell people that if you can have a doula, and if you can afford a doula, there are many community programs that will offer doulas to be able to support you with information, spiritual support, physical support to help you through labor and childbirth. That is not necessarily a family member who can be that advocate for you. Remember this, you're propagating the human species. You deserve respect and you deserve reverence, and don't expect to be treated as anything other than that.
And yes. And I think it's also important for the community to ask the hospital, what are your rates? What's the proportion of staff members that look like me, whether you're Black or you're Latinx or you're Asian Pacific Islander? Just ask if they have a tour of the hospital. Does your hospital invest in people in the community outside of the folks who are going to actually generate the revenue to go to their hospital, right? If the hospital is really committed to equity, it should be thinking about all the folks who are pregnant and birthing. If we're really wanting to have a community-driven justice equity lens, it shouldn't just be about who's going to show up in my hospital, right? So I'd have to call out MLK Hospital because some of their programs, and Tammy Turner, because their programs are for people who are pregnant and birthing, period. So ask the hospitals, what are you doing for folks like me, not just the ones who are going to show up at your hospital, but what's your commitment to perinatal health equity? What's your community benefits report? Where was the community in that report, right? And your community needs assessment. So I think that there are questions, simple questions that people can ask to see, is this the hospital for you? Because if they're not going to respond to you and their responsiveness should be based upon what they're currently doing, then maybe if you have the power to go elsewhere, do it. But I think we need to be asking these questions around who does your staff, how do they respond, what are they doing, what are the community organizations that are a part of your hospital? Do you even invite the CBOs to be on your board of directors? Or are they advising the policies and protocols and procedures? Simple questions you can ask, and based upon the response, you should get a sense of how it's going to be.
And I feel like even when Charles was saying, Cedars-Sinai had a bundle, a hemorrhage bundle, but he didn't know. So just even asking about that. And so if something were to happen, you should say, bring out the bundle.
I don't believe that hospitals are required to report their statistics on maternal mortality or complications at all. And Cedars-Sinai is an interesting example because there's a group called Leapfrog, and you can look up your hospital online at, I think it's leapfrog.org, and they rate the hospitals for patient safety across the country. So you want to, there was a period of time, for example, when UCLA, much vaunted as it is, got one of the 2 Fs in the entire state. And they have cleaned up now, but there was a time. And it's not completely transparent because Cedars-Sinai does not dodges some of the statistics by not reporting. They simply refuse to report. But you can check hospitals on leapfrog.org. And you can, there's almost no way to check your doctor, but you can check their arrest record, which the state board does not do. And in fact, if doctors are arrested with a drug problem, an alcohol problem, with prostitutes, with whatever, they are only required to self-report to the board, which, as you can imagine, they don't do. And it's a big problem. And so you can look up the arrest record yourself. And you can also go to ProPublica.org to look up your doctors, how much money they take from industry. Because doctors who are taking major sums of money from pharma or from medical devices are doctors you do not want to see. And it's all in the record. That's in the public record at ProPublica.org, and you look up dollars for docs. Okay, so go to ProPublica.org, and you look at their feature called Dollars for Docs. You fill in your doctor's name, and they will tell you how much they take from pharma, from medical device companies. And many take nothing at all, but there are some on there taking $57 million a year from device companies or from pharma, and you don't want that doctor.
We're going to have Charles say something, and then we're going to open it up for our Q&A.
So I was just going to touch on transparency, right? And all those are, thank you for sharing those. So those are outstanding resources. One of the things that we did that we're really proud of is that we partnered with Yelp. And at the end of 2017, starting in 2018, how many of y'all have ever used Yelp when a waiter just, right? So Yelp, of course, is the #1 customer review site in the world. Yelp actually added critical birthing data for every hospital in the state of California, right? So now you can go on Yelp and pull up C-section statistics, right? Episiotomy rates, very, very, very. And so our hope is that the transparency in a lot of cases will be that hammer, right? And by having this data more readily available, it will encourage hospitals to be less C-section happy, right? To be transparent with their data because it's going to reflect. And if you're looking at UCLA versus Cedars and you're seeing rates, and you're seeing reviews that are ridiculous, I also want to talk really quickly about accountability and the medical board, right? There's a huge problem going, I have to call them out. There's a huge problem going on in the state of California with the state of California Medical Board giving ridiculously low disciplines to doctors who have had everything from sexual assault to repeat offenders to wrongful deaths. In Kira's case in particular, after the state of California concluded their medical investigation, they not only found that the doctor, one of the main doctors responsible for Kira's care, was grossly negligent, obviously, for Kira's death, but he was responsible for the near-miss deaths of 6 other women, 3 of which happened in a 3-month time span of Kira's death, okay? So it begs the question on the hospital side, what was he even still doing at Cedars-Sinai with this track record? And then further, anywhere, right? Why do he still have his license? But here's where it gets scary. So you have all these layers that I talked about before, but then you have a lack of a breach of public trust because the state of California Medical Board disciplined him with 3 years probation. He is still practicing medicine in the state of California with little more than a slap on the wrist. And that 3 years probation is far below the state of California's minimum sentencing guidelines, right? So there's all these issues, right? It's discipline, it's transparency, and then accountability, right? The majority of these men and women who have committed their lives to these practices are great people. However, the ones that aren't and the ones that are repeat offenders and bad actors have to be held accountable,
All right, do we have any questions from the audience?
Hi, my name is Cynthia Riddle, and I'm a near miss. It's my birthday today, and
Happy birthday.
Thank you.
Birthday.
And I am darn lucky to be here from the last 30 years, and maybe it is because I'm white, but I experienced a lot of things that I think contribute to this, and I think the addition of Black mothers goes one step further, but I was blown off so much. I went in I had preeclampsia, and I went in 3 days prior to my emergency C-section to my doctor's office and said, four of my friends had preeclampsia. I'm almost positive I have it. My blood pressure was elevated. I'd had a bad gestational diabetes test before that he'd blown off. Blow off is the word. That male doctors sometimes just blow off women in general as hysterical, or you don't know what you're talking about. I ended up in the hospital at 3 o'clock in the morning with a blood pressure of 214 over 134. They tried magnesium sulfate, and my blood pressure was so high I kept blowing it out. So they had to do an emergency C-section. And again, talk about blown off. The doctors, as they were performing my emergency C-section, I was awake for it with an epidural, were talking about their golf games. And like there was no big thing, and there was no rush, and there was no anything. And after, when my daughter was rushed off, she was 9 weeks premature. I was at 31 weeks. When she was rushed off to the NICU, they put me in a room by myself. They didn't have it. This is like no space thing. They had no space available in the ICU for me. My blood pressure was still really elevated, and they left me alone for 4 hours. Made my husband go and stay outside the NICU, but wouldn't let him be with our daughter or see anything. And just, there was blow off after blow off. When my daughter had an EEG to determine whether or not she was mentally, damaged by all of this, the doctor left us sitting for 3 hours. He had claimed he had an emergency C-section. Then when he went home because he was tired. So there's so much blowing off that happens. And I think what was so excellent about your episode, I cried during your episode, and I cried even harder, Charles, after seeing the beautiful tribute to you and Kira at the end. What I think you got so right is just the blow-off factor. Short-staffed, nobody paying attention to obvious, problems and symptoms that are there. And hearing what these statistics are is just absolutely horrifying. So anyway, I want to thank you, Amy, Tiana, Chris, and Charles for sharing your story, for telling such a beautiful thing, because I thought, like most people do, I was young at the time, I was healthy, I was thin, it should have been a simple, easy pregnancy. And I thought, like most women do, this is gonna be no big thing. The biggest thing I was worried about was how much it was gonna hurt. And looking back on it now, I am so incredibly blessed 30 years later to be having my birthday today. My daughter just got her PhD. She's turning 30 in a couple of months. She just got her PhD, and she and her longtime boyfriend just got engaged. So I'm blessed to be here, and maybe I got a little bit better care because I was Black, but I felt like I got terrible care too. I think that women in general, women's health care in general, we look at what's going on in all these states today, Anyway, thank you guys for this. Thank you.
Thank you for sharing.
Thank you for sharing.
I have a statement. Awesome. I have a
There you
statement.
go, Mike. Go, Mike.
There you go.
I have a statement, and in reading Medical Apartheid, J. Marion Sims, who built the practice and the study of gynecology, exclusively did his horrendous experiments on Black slaves with no anesthesia. The speculum were 2 soup spoons. He started with 2 soup spoons opening the vagina of women. And his whole practice, so now he's the father of gynecology, which is, please get the book if you have it, Medical Apartheid.
Harriet Washington.
It's awful. It's just awful. And this, even though I'm not going to have a baby, but this also goes into other medical care for Black people. I have an elective surgery coming up. Thank God it's elective. I'm scared to death now. Now I'm totally reconsidering the surgery because I'm afraid of what kind of care am I going to get. The other thing is, would maternity hospitals, strictly maternity hospitals, kind of alleviate some of these problems? My son was born in a maternity hospital, Margaret Haig Maternity Hospital in Jersey City, New Jersey. And even though I was very, very young at the time, I'm wondering if I survived it because it was a maternity hospital and their focus was on the birthing mother.
Oh, yeah, I didn't know you were going to answer two questions.
So
maternity hospitals kind of alleviate some of this?
that's a tough question to answer. The question is, would maternity hospitals, exclusively maternity hospitals, focus on birthing people, ameliorate this problem? And that's a hard question to answer because hospitals and healthcare systems have been so perversely incentivized to use maternity care, again, robbing Peter to pay Paul, right? I mean, everyone knows that, well, a lot of people in healthcare know a dirty secret is that if you have a neonatal intensive care unit, a NICU, that's the driver, right? That's going to make you some money because we made a decision years ago that all NICU visits should be covered, and that should be money that comes to hospitals and institutions because we didn't want parents to have to worry about, getting the care that they needed for their baby that was in a NICU. So you have a perverse incentive to have a certain number of NICU admissions, right? Whether or not they're necessary. Our system has gotten to a point where maternity and NICU are the money makers. I guess that's the easiest way for me to say it without getting in trouble, in the hospital. And so if they exclusively stood alone as a specific service, that would require a prioritization of women's reproductive health across the spectrum, and we've never seen that. And a different funding model, not only for those maternity hospitals, but for every other hospital that would remain. So that's a tough question to answer, but it's an interesting idea, and I'm sure that there are people who have thought about it, but that's probably the best I can do. Karen?
I agree. I mean, I think that, hospitals need to make money, right? And even the designation of the level of hospitals is based on the NICU and not the maternity care. And so there's lots of, we can chat, but there's lots of things that
that would have to change.
Drastically. And it's a model that's really driven by money. So hospitals have sometimes people birthing to generate some of the income, but then you'll see some of the other specialties get more services and support from the institution, like some of my other surgical peeps, I'll say. But we would have to prioritize birthing people. And most of the time, no. I mean, look at this. Look when I say like barometer is your infant mortality rate and your maternal mortality rate. That tells you how well the country values family and birthing people.
Hi, I'm Simbi. I'm a filmmaker, but I'm also, I should say, a part-time doula. I've only helped. I've helped deliver 3 babies and been peripherally involved in some other births. And so I have a 3-part question, actually. One, I've noticed there is, I don't know the numbers, I can't remember, but like a really huge increase in America of planned cesarean, so not necessarily an emergency cesarean. I'm wondering what the correlation is between that and the high mortality rates. Piggybacking on your question, I'm wondering about birthing centers, like what your feelings are there versus hospitals. What I've seen good things there, but I've also seen where there's trouble, like you've paid for that birthing center, and now they don't actually have the equipment to help you, and then now you're paying for the ambulance to go to the hospital and do a whole other thing, which is not the case for everybody, but I've seen that a few times. And then I'm just also wondering, with the doctor, sort of the length of care of the doctor. So like I don't have children yet, but I've had the same OBGYN for 15 years, the whole time I've lived here, and who's now become a concierge doctor. She actually did the Kardashian babies. That's a whole other thing. But who doesn't take insurance anymore? And so it seems that people who maybe already had a relationship get different kinds of care if that doctor shows up to deliver versus people who, right? So then you have to pick somebody who says, I'm your doctor, I'm gonna be there, I don't do cesareans. Like I helped one friend, and sadly this was at Cedars, and it was actually I was surprised, a Black female OBGYN. My friend was having her first baby, she went in with pain, and I was like, I think she has fibroids and blah, 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 and this is what the pain is, which is, again, very common in women. And she shut me down, and I was like, I think she's having a girl, and she had told her she was having a boy. And I said, if it's a girl, the estrogen, and it's gonna make the fibroids grow even more. And she just shut her down and just wanted to give her drugs and put her on bed rest. So I took her up to my doctor, And sure enough, she was having a girl. She, did have fibroids. She didn't need bed rest, and she was taken care of in a different way. Another friend whose baby was cesarean, they just wanted to, do was baby who was breech, and they just wanted to do a cesarean. And again, to me, like, a good doctor knows how to flip the baby, before. And they don't even teach that anymore now. So I'm just wondering about those three things, like, how do they relate to this?
So I could talk about this all night, so I'm definitely gonna come grab you at some point, but I'm gonna try to make this really quick. So primary C-section is actually one of the drivers, at least in Black women, around maternal morbidity and mortality, and there's reasons for that. So the planned piece is a different conversation, but in the statistics that you hear from the CDC, it actually is not a planned or a planned repeat C-section. It's actually primary C-section, and mostly in what we call nulliparous individuals or people who've never had a baby before. So that's that piece. I want to say something that has gotten me in trouble recently, but I think it's really true because you said it already, and that is, in some professions, and I would say nursing and some of our physician colleagues, like some of us have lost our skills. Like at San Francisco General Hospital, we're one of the places that will do a breech birth because we have skilled practitioners who know how to do that. But every birthing hospital sends anyone with a potential breech birth to the general, right? So there's this need for going, again, using the language of investment, right? We need to reinvest in models of care, concierge, boutique, all of that. But again, coming back to, because we have such an insurance-driven model of payment in the United States, that employer-sponsored insurance and public insurance are really driving the quality of care that people can receive. And we all have to agree, or not, that that is how we want to continue to provide health services in the country. I remind people, we could actually change that if we wanted to, right? So, but we have to have that discussion, and then we have to make the decision that that's what we want so that people can have the appropriate level of care to what they need and what their experiences and preferences are. I am a big fan of birth centers, and I know many of the people who run the birth centers around the country, whether it's in Minnesota or Washington, D.C. We know women of color who are, running birth centers that are getting superior outcomes. We know that. But again, 98% of the births in the United States happen in hospitals. And so we need to remember that if that's the bulk of the geography and the place where those births are occurring, then we have to have system level changes across, the birthing health services in order to be able to see improvements. It can't just be in one place and not throughout the entire system.
Only going to add because I have to do, because my funder would be like, why didn't you say something? So because 99% of the births are happening in hospital settings, we, being the California Maternal Quality Care Collaborative, for which I'm the director of the Birth Equity Collaborative, we are working directly with Black women-led community-based organizations to reframe what birth looks like in the hospital setting. And we're working with pilot hospitals, but we're actually having communities define a patient-reported experience metric, a measure of respect and dignity. And we're also having the Black women-led CBOs inform our quality improvement activities, from our education for our providers to having a local advisory group be associated with the hospital based, comprised of community people, and having community inform what an effective, sustainable community hospital partnership looks like. So we are doing that because the births right now are happening in the hospitals, and the site of death are in hospitals. The data is not coming from failed birthing centers. The data is not coming from failed doulas or failed midwives. It is under the care of a physician in a hospital. And so that's why this pilot is necessary, because we're going from where the harm is happening, and hopefully can redesign that with Black women-led CBOs and Black birthing people and Black mothers.
Well, we actually have to wrap this up. I see lots of hands. I think people will be here after for a little while. I just wanted to say this quote from William Callahan from the CDC that I thought was really interesting. The experience of being Black in America is so fundamentally different from being white in America that it translates to health outcomes. So I just thought that was really interesting from all of the research that he had done as a white man to come to that conclusion. Yeah. And I also wanted to give a shout out before we go to your organization, for Cura for Moms. And that should be something that we all...
Yes, so For Cura for Moms is the organization that we have.
The number 4.
Yeah, the number 4, exactly. So thank you. So the number 4, KIRA, the number 4, Moms, MOMS. And so you can, it's at For Cura for Moms on all social media, forcuraformoms.com. And you keep up with Two Little Rascals and me. You keep up with all the wonderful work we're doing. And, you know, a lot of really exciting things we're going to be doing this year and far beyond. So to continue to raise awareness, but most importantly, the highest tribute that we can pay these women is to do everything we can to send other mothers home with their precious babies. So.
Round of applause for Zoanne and our panel. So before I let you all go, I know you probably have burning questions, and I think some people are happy to stick around for a little while, and we would like to get a group shot of all of our panel and everyone together. But for those of you who are professional storytellers out there, whether you're in the news media or the entertainment media, or even if you just go home and talk to your own kids or your husband or somebody, there's a ton of stories here that have not been told. To my knowledge, I think between Grey's Anatomy did an episode last year about hemorrhage cart. The Resident did this amazing episode about Charles's experience. As far as I know, and I watch TV for a living, these are the only 2 television shows, narrative television shows, that I've seen that have dealt with this issue at all. So there's a lot of opportunity to tell these stories to your audiences with the kinds of characters that are on your shows. So I'm, I don't mean to pressure you, but, I know where you all live now. So, anyway, there's lots here. And Hollywood
Please pressure him. Please pressure him.
And we're here to help you. If you decide you want to write about this and you want to follow up with Charles or you want to follow up with Karen or Monica, give us a call. We'll connect you with them, or we'll connect you with others who can share their experiences as well. So again, thank you, Charles. Thank you, Amy. Thank you, Monica. Thank you, Karen. Thank you, Zoanne, moderator extraordinaire. And I'll ask for, I don't know, who do you want up here? Photographer. Michael.
We'll have the panel.
Okay, so we're going to do a few photos, but feel free to stick around for a little bit and follow up with any of your other questions. And thank you all for coming.